In this sketch, we'll be covering C. difficile. That C once stood for Clostridium, but alas, phylogenesis has revealed that it is not, in fact, a clostridial species. Imposter, I say! So, now that C stands for Clostridioides. So, Clostridioides difficile. For reasons that are as obvious as they are disgusting, we've set our C. diff sketch in a chocolate factory. While it may be upsetting to think about, it's also highly memorable, and that's what counts. Anyways, here at the factory, cluster candies with different flavors are the specialty. Moving on with the tour, it's easy to see why C. diff was originally classified under the genus Clostridium. They have a lot in common, at least when it comes to basic features. Like Clostridia, C. diff is a gram-positive bacillus and an obligate anaerobe. We've included some purple rod candies in our chocolate stream to remind you of C. diff's morphology. And the oopsie poopsies are wearing our recurring symbol for obligate anaerobes, anaerobic gas masks. Also, like Clostridial species, C. diff is a spore former. Bacterial spores are notoriously hard to kill. They are resistant to a whole bunch of stuff, including heat, radiation, and many chemical agents. Walnuts are our recurring symbol for bacterial spores, so we've sketched some walnuts ready to get layered in a coat of chocolate. Yes, definitely chocolate. Remember, millions of bacteria, yes, even the bad ones, are quietly present throughout the human body. This is called colonization. However, if something, like an antibiotic, throws off the balance, the bad bacteria can grow and spread, causing some nasty symptoms. This is called infection. C. diff can be considered part of the normal gut flora, which is why we've included these normal candy flowers. The development of C. diff infection usually requires two factors: the presence of an infectious strain of C. diff in the gut, aka toxigenic C. diff, and disruption of the intestinal flora. We'll start with toxin-forming C. diff. It turns out that even though you can be colonized by a bad C. diff, most of the time C. diff infections are actually caused by new transmission of toxigenic strains. How does one acquire this lovely organism? Well, transmission is via the fecal oral route, specifically through the ingestion of spores. That transmission usually occurs in the hospital, making C. diff a nosocomial or hospital acquired infection. To symbolize recent hospitalization as an important risk factor, we've included this first aid kit. But keep in mind that in recent years, there have also been an increasing number of community acquired infection.
Is nowhere safe.
Either way, C. diff's spore forming powers make preventing transmission challenging. Remember, spores are relatively resistant to chemicals, and that includes alcohol based hand sanitizers. So, what's a grimy handed med student to do? Old fashioned hand washing with soap and water, of course. C. diff is known for hitching a ride on the contaminated hands and clothing of healthcare providers. So, whether you're dealing with chocolate rivers or your patients, or some combination thereof, heed this sign's suggestion:
Wash your hands. Seriously.
In the hospital, cases of C. diff infection require contact precautions, meaning it's time to don a gown and gloves each time you enter the room, as demonstrated by the oopsie poopsie foreman over here. Alright, let's get back to the factors typically required for development of infection. Once again, factor 1 is the presence of toxigenic C. diff, most often a newly acquired strain. Factor number 2 is recent antibiotic use. This is because C. diff, even newly acquired toxin producing strains, is normally kept in check by gut bacteria. But antibiotics can wipe out those good gut bacteria, allowing C. diff to replicate unchecked. Any antibiotic can cause C. diff infection, but the most notorious offenders are clindamycin, fluoroquinolones, penicillins like ampicillin, and broad-spectrum antibiotics like certain cephalosporins. You will see these symbols a lot as you travel the Sketchyverse. We have our clean clindamycin, fluoroquinolone flowers, purple penicillin, and cephalosporin cephalopod. Proton pump inhibitors, and to some extent H2 blockers, also increase the risk of C. diff infection. These drugs decrease the acidity of the stomach, allowing spores to germinate into their vegetative, infectious form. You'll meet the PPIs, like omeprazole and other prazoles, over in Sketchy Farm. Just look out for our recurring prazole parasol. As we've mentioned, only toxic forming strains of C. diff cause infection. There are two toxins to know about, A and B, or in this case, Althea and Bartholomew. And before we dive into the nitty gritty of these toxins, let me emphasize that all of this is happening in the colon. Specifically, toxins A and B act on colonic mucosal cells, represented here by these cell-like gummy bears. Colon gummy bears. Tasty. Toxins A and B enter these cells and start wreaking havoc, disrupting the cytoskeleton within the cells, as well as the tight junctions holding the cells together, as illustrated by these toxic youths greedily grabbing at the licorice cytoskeletons of these poor bears. The cells begin to round up and retract. The result is increased paracellular permeability, which causes fluid to shift into the gut lumen and, as you might imagine, copious watery stool. Everybody brought their own spoon, right? No? It's okay, we can share. The toxins also mediate an inflammatory response and cell apoptosis, and what you're left with is a layer of hungry neutrophils rushing to the site of inflammation, and a bunch of dead mucosa cells. This is called pseudomembranous colitis due to the formation of pseudomembranes, which can be seen as patches of yellow-white necrotic material scattered over the mucosa or in a confluent sheet. As we may have mentioned, C. diff typically presents with high-volume watery diarrhea. This is no babbling booty brook. This is a gushing waterfall of diarrhea. C. diff diarrhea is notorious for its strong, characteristic smell, which has nothing in common with the rich, decadent smell of my chocolate. Trust me. The diarrhea may be accompanied by fever and leukocytosis. The feared complication of C. diff infection is toxic megacolon. No, not the baddie from a weird anime, a non-obstructive dilation of the colon. It can lead to perforation if left untreated. So, how do we know if a patient's diarrhea is caused by C. diff? The diagnosis is made by testing stool for toxic-producing C. diff. Remember, only strains that produce toxin cause infection. There are two important ways to detect the toxin. The first is polymerase chain reaction, or PCR, for toxin-encoding genes. PCR is a type of nucleic acid amplification test, otherwise known as NAT, which is why we've included a swarm of gnats above this unfortunate toxin kid. And take a look at the oopsie-poopsie trying to pull him out of the river with an antibody stick. The second type of test, EIA, or enzyme immunoassay, uses antibodies to detect the toxins themselves. It's also important to know about a third stool test, enzyme immunoassay, EIA, for glutamate dehydrogenase, symbolized by this crate of gluten-free candy. Glutamate dehydrogenase is an enzyme found in all C. diff organisms, hence the big question mark. Because this test cannot distinguish between strains that produce toxin and those that do not, it is never used alone to diagnose C. diff infection.
On to treatment!
The first is vancomycin, specifically oral vancomycin. So we've drawn in our vancomycin van, complete with a creepy mouth-like design. When taken orally, vancomycin has poor systemic absorption, which is actually a good thing here because the drug stays in the gut where the bacteria are and doesn't cause any systemic side effects. Who can take a sunrise, sprinkle it with poo, covered with an antimicrobial or two? The candy van. The candy van can. Another treatment option is oral fidaxomicin, represented by this oopsie-poopsie fiddling on the tongue ramp. This is a macrocyclic antibiotic, similar to the macrolide family. Like oral vanc, oral fidaxomicin has minimal systemic absorption. Perfect for combating a gut bacteria. While oral antibiotics are effective in most cases of C. diff infection, severe cases are a different story. That's because severe C. diff causes slowing of intestinal passage, also known as ileus, which delays delivery of oral agents to the colon. To ensure an antibiotic is reaching the site of bacterial infection, an IV drug, usually metronidazole, is given in addition to oral vancomycin. Hence why we've included our recurring metronidazole Metro covered in IV.
That's the M train making a beeline to D-Town. D for diarrhea. All aboard!
But what happens when antibiotics fail to do the job? They say sharing is caring, so fortunately, there is a very effective non drug option available for cases with multiple recurrences and antibiotic failure. That's right, kids. OPP. Other people's poop. Or if you want to get all formal about it, fecal microbiota transplant, FMBT. With proper, controlled transplantation, stool from a healthy donor restores the recipient's gut microbiome and suppresses the growth of C. diff. And now, we're done with C. diff. Since you made it to the end, it's my pleasure to inform you that you're now the sole owner of this entire diarrhea chocolate factory. Song time. Come with me, and you'll be in a world of toxic megacolon. Take a look, and you'll see a messy diarrhea junction. We'll begin with a spin, traveling in a world of really bad infection. What we'll smell will defy normal olfactory expression.